Today our topic of discussion is corrosive poisoning. So the term corrosion derived from the Latin word to know. The corrosive ingestion remains a common problem in developing countries such as India. It can pose a significant management challenge due to devastating effect of the upper gastrointestinal tract in the acute and chronic phases of the injury. Corrosive substances can be classified broadly in acids, alkalis, heavy metals, formalin, iodine stricture and other chemical substances. Sodium hypochlorite, a natural alkali constituent the household bleach, was the most commonly implicated corrosive agent in the Western world. In developing countries such as India, where acids are more commonly used in toilet cleaners compared to more expensive caustic soda, acid contributes the most of the corrosive injury. Corrosive ingestion could be accidental or suicidal. Accidental corrosive ingestion is frequent in children who unintentionally ingest household cleaning products. Suicidal ingestion tends to be associated with higher grades of tissue injury in the oral cavity, oropharynx and proximal esophagus, as they tend to ingest it with some hesitancy, whereas accidental intake is often associated with rapid consumption of corrosives in more substantial amounts without knowing that they are corrosives and highly and usually frequently associated with gastric injuries. Pathophysiology and pathology. Corrosive substances with pH less than 2 or greater than 12 are highly corrosive and can cause tissue necrosis. A concentrated solution of sodium hydroxide 22.5% and 30% in contact with esophagus can produce perforation of the esophageal wall, mediastinitis and fatal outcome for 10 seconds or for 1 second. So 30% can cause esophageal perforation within 1 second. In contact with acid, the tissue protein are transformed into acid proteins and hemoglobin is transformed into hematine. So the final outcome is so-called coagulation necrosis. So acid causes coagulation necrosis, while alkalis result liquefaction necrosis. The severity of the chemical burns that affect the entire gastrointestinal tract depends on the several factors like nature of the corrosive substance, pH value, the quantity and concentration ingested, and the duration of the exposure and the act of swallowing. The tissue injury following corrosive ingestion goes through 3 phases. Phase 1 is acute necrotic phase that lasts for 24 to 72 hours. Second phase of mucosal sloughing and with ulceration and fibroblast colonization that lasts for 3 to 12 days. Phase 3 in the stricture formation occurs and cicatrization scarring takes place. It approximately occurs in 3 weeks after the initial injury and continue for 3 to 6 months or more. Classification is classified as burn like first degree, second degree and third degree. First degree superficial damage followed by onset of mucous edema and erythema. The affected mucous layer regenerates within few days and usually does not manifest complications such as scar or stricture formation, while second degree caustic penetration through the submucosa into the muscular layer of the organ. After 1 to 2 weeks, deep ulceration and granulation tissue developed on the esophageal or gastric wall. Production of the collagen tissue lead to contraction over a period of several weeks or months. Those processes along with the neighboring injuries may cause narrowing of the esophageal or stomach lumen within next 8 weeks to 8 months and stricture or stenosis may appear. The third degree is characterized by perforation of the wall of the esophagus or stomach. Clinical features. Clinical manifestation depends upon the extent of the injury. In the mildest form, the patient may be asymptomatic or presents with mild symptoms like throat pain with normal or mild erythema of the oral cavity mucosa. However, in moderate to severe injuries, the patient presents with significant symptoms. Odontophagia and dysphagia signify extensive esophageal involvement, whereas stridor and hoarseness suggest upper airway involvement. Epigastric pain and hematomesis point to gastric involvement. Respiratory distress with tachycardia and drooling of saliva suggests severe injuries. The presence of abdominal tenderness and peritoneal signs is an ominous indicating gastric necrosis. Gastric or esophageal perforation can occur at any time during the first 2 weeks. although the incidence is the maximum between 3 days to 12 days following the ingestion. Therefore, change in the patient's clinical course in form of worsening abdominal pain or development of the chest pain requires immediate radiological evaluation. Post-corrosive late complication. So the stricture and stenosis of the esophagus, difficulty in swallowing and feeling of pressure behind the sternal bone are the most common symptoms indicating narrowing of the esophagus. Appear the 3 weeks to 3 months after ingestion of corrosive substance. Most common site is cricopharyngeal area behind the bifurcation of the trachea. The complications, this is a radiological picture of the esophageal stenosis. Now, stenosis of antrum and pylorus. Onset of symptoms of full stomach, nausea, vomiting and weight loss suggests gastric obstruction. It occurs rarely than esophageal stenosis, often 5 to 6 weeks after the ingestion. It is most frequently found after acid ingestion. Esophageal and stomach carcinoma, development of carcinoma might happen 40 to 50 years after ingestion of the corrosive substance. This is the stenosis of stomach. Now management divided into 5 parts: initial resuscitation, evaluation of the grade of injury, treatment of early complication, maintenance of nutrition and prevention of the stricture formation. The first, initial resuscitation. The basic principles of resuscitation with the maintenance of airway and circulation should be followed. Supportive care rather than specific antidotes is the mainstay of the acute phase treatment. Gastric lavage and induced MSCs are contraindicated as this result additional esophageal injury. Neutralization of acid with alkali and vice versa is not recommended as heat generated by the exothermic chemical reaction could aggravate the tissue damage. But there is a controversy. Practically, some authors has the physician use neutralization of acid and alkali. Like with acid, for alkali we use caustic soda, vinegar, vinegar, orange juice, all this used for the lemon juice used for the neutralization of alkali, whereas milk for neutralization of alkali and for milk for acids. Dilution of corrosive with the milk or water has a little role. Intravenous proton pump inhibitors are usually given in the patient with the higher grade injuries to minimize damage to the injured gastric mucosa to avoid the exacerbation of the esophageal injury by superimposed gastroesophageal reflux. Corticosteroids do not prevent the development of the stricture following corrosive ingestion, and it's reverse for the patient with airway involvement. There is also controversy regarding corticosteroid use. Some usually use corticosteroid for the prevention of the stricture formation. Routine use of broad spectrum antibiotic is not recommended except in the patient with high grade of injuries and those receiving systemic steroids. Evaluation of the grade of injury by biochemical parameters suggestive of transmural necrosis are metabolic acidosis with the elevated lactate level, leukocytosis, thrombocytopenia, high CRP level and deranged liver function test. Plain X-ray is value in patient with clinical suspicion of perforation as they may show presence of free air. Traditionally, early upper GI endoscopy performed within 48 years of the ingestion and has been recommended as the mainstay of investigation to decide further management. The finding on endoscopy is usually graded using the classification proposed by Zagar et al. Grade 1 is the only erythema or edema. Grade 2A. Grade 2 is divided into 2A and 2B. 2A is hemorrhage, erosion, blister, ulcer with exudate. Grade 2B circumferential esophageal ulceration. 3A similarly divided into A and B. A is scattered deep ulcer with brown, black and grey discoloration. 3B extensive deep ulcer with brown, black and grey discoloration. Grade 4 is esophageal perforation. Grade 3A scattered deep ulcers with brown, black and grey discoloration. Grade 3B extensive deep ulcer with brown, black and grey discoloration, and grade 4 is esophageal perforation. But the fact is that the endoscopy, first of all we have to endoscopy within 48 hours. We have to avoid the endoscopy between 3 to 12 days, 3 to 15 days, because there is a chance of iatrogenic perforation. First of all. Second is endoscopy's result are subjective, vary person to person, or inter-observer variation is there, and the depth of tissue injury or necrosis that cannot be ruled out properly by endoscopy. So there is a change of management according to necrosis, presence of necrosis or not. So there is a controversy regarding use of endoscopy, early use of endoscopy, whether it is helpful or not. So recent studies have shown the CCT neck, thorax and abdomen performed 3 to 6 hours after corrosive injection is superior to endoscopy to detect transmural injury of the gastrointestinal tract. Emergency surgery is indicated in patients in whom initial evaluation suggests transmural necrosis of the GI tract. Now nutrition. Extensive damage of the gastrointestinal tract hindered the physiological nutrition in this patient. Within a short period of time, this patient fell into a severe general condition due to hypercatabolic state and negative alkali balance. In patients with grade 1 and 2A grade, and total parenteral nutrition in first for 24 to 48 hours followed by liquid diet until the 10th day. Afterwards, food intake can be a more liberal regimen. In patient with grade 2B and grade 3 of damage is so-called esophageal rest. So during the rest phase, the patient is fed by nasogastric or nasoenteral tube. So gastrostoma or jejunostoma and parenterally by peripheral or central vein. So this time we have to give rest to esophagus. Nothing is allowed, and nothing per mouth is recommended during this phase. Now prevention. Now prevention of stricture formation. Esophageal dilatation. Retrograde intraluminal esophageal dilatation is performed for the prevention or dilatation of the already created esophageal narrowing. According to some authors, it can be done immediately after injury or 15 days after injection. The predominant attitude is that it is the safest to start with the esophageal dilatation 6 weeks after injection. Then it is performed every 2 to 3 months in several consecutive times intervals. Sir.
এখানে এখন কি 2B and 3 গ্রেডে nasogastric RALS to be okay না in this situation?
I think ও সবকটা অপশনে লিখেছে এনজি করতে হবে
কখন করবে RALS টিপ
RALS to is like initial 24 hours and I think it's okay.
I think
না এখানে সবই লেখা আছে যে রাইলস টিউব
not blindly endoscopically যদি করে দেয় if they see and they don't think that it is too bad and করে দেবে না endoscopically they can place a RALS
blindness the normally করা হয়
you have no idea হয়তো pharynx through দিয়ে চলে যাবে
স্যার 2B আর 3 গুলো সুপারফিশিয়াল ইরোশন তাই তো
আর সেটা তো ডায়াগনোসিসটা হচ্ছেই
এন্ডোস্কোপি ডায়াগনোসিস রাইট
হ্যাঁ
so I think ওরা যখন endoscopy করতে যায় তখনই বলতে হয় যে if possible please place it
Yes, sir.
that is
NG2 so no blind attempt
no not
দুটো ক্লাসিফিকেশন আছে অ্যাকচুয়ালি
পাঁচটা আছে না চারটে
না দুটো আলাদা আলাদা একটা কিন্ডেল না কি একটা নাম হ্যাঁ এটা সরি Now prevention of stricture further sucralfate use. There are subjective reports that the use of sucralfate may decrease the percentage of the post-corrosive stenosis in the upper GI tract, but there is a controversy regarding use of sucralfate. Esophageal.
Make sure it is given orally, not through RALS tube. Maximum sisters give through RALS tube. These are no use.
Esophageal stent in patient with grade 2B and 3 grade of esophageal injury, a specially designed intraluminal stent under endoscopic guidance may be placed preventively or after onset of stenosis. Prevention of stricture by surgery. Surgical intervention is indicated when there is a complete stenosis that cannot be treated with usual conservative method. Defect of esophagus or stomach detected with the X-ray examination, and if there is any fistula formation. Now prognosis. Prognosis in acute corrosive poisoning is variable and that depends on the degree of the esophageal and gastric injury as well as general health condition of the patient. The highest mortality rates has been recorded as a result of perforation and mediastinosis. So this is a chart how we proceed for a case of acute corrosive ingestion. So first, whether we have to see whether there is any presence of peritonitis or mediastinosis with the hemodynamic instability present or not. If there is a hemodynamically unstable patient, then we have to opt for emergency surgery. If there is no hemodynamic instability or evidence of peritonitis is not there, then but we suspect that there is a severe injury, then we have to go for better to go for CT, neck, thorax and abdomen. As I told earlier, 3 to 6 hours within. So there is a grade 1, grade 2 and grade 3. It is CT scan grading. Grade 1 is normal organ, grade 2 is a post enhancement after construct and grade 3 is no enhancement after giving dye. So grade 1 injury, no endoscopy and early discharge. Grade 2 injury, it is a non-operative treatment endoscopy if CT scan finding are uncertain. So in that case we have to go for endoscopy for grade 2 injury. Grade 3 injury, there is a indication of emergency surgery.
Emergency surgery should be.